احنا will be moving to the third and also very, very important topic about myocardial viability before revascularization in heart failure, whether it's always needed ولا لأ. اللي هياخد البرو سايد بروفيسور السيد فرج, professor of cardiology Zaqazaq University. I'm sure it will be also a very challenging topic as the previous two.
Mr. Chairman, thank you, Professor Hasham, for this kind introduction. Actually, we need these waves of heart failure CMEs because the importance of heart failure, and also because the importance and innovation of the drugs and the evidence which is coming up every day. Actually, in this morning in the National Heart Institute, we discussed some issues like this about the viability, especially in those patients with chronic total occlusion. Do we need to do or not to do? I think we have a lot of debatable evidence, and I think, I hope that me and Professor Tariq cover this debate. ما بينقلش. Of course, I will take the Bruce side. In 2018, this is a very important publication in the International Cardiology, Intervention Cardiology. Left ventricular dysfunction remains one of the best prognostic determinants of survival in patients with coronary artery disease. As we all know, revascularization has been shown to improve survival compared to medical therapy alone. It's also known. Viability testing can help direct patients whom will benefit from the most from revascularization. The modalities here of the viability, like SPECT, dobutamine stress echo, CMR, positron emission tomography PET, imaging, all those are the modalities we can use to assess the viability. But what's more important here is the use of the combined modality to assess the viability, as we will see. Are the most common modalities for assessing myocardial viability. Viability testing can help differentiate which patient benefits from chronic total occlusion intervention, for example. As I said, we discussed this in this morning. Here, a very important table also, which is published in 2020, just maybe 1 month ago, about the modalities, the sensitivity, specificity, positive predictive value, and negative predictive value of several modalities of viability assessing. And we can here notice a very important thing, that the sensitivity, specificity, positive predictive value is much more higher and much more sensitive, specific with positive predictive value with the CMR. And this is here a very important point. Why? Because in the trial, like STITCH or Part 2 trial, they are using the dobutamine stress echo and SPECT for assessing the viability and for taking the decision. There is no trials just now using the CMR to assess viability and to assess the decision making, and this is a very important point. Here also the patterns of the viability, which we know the pattern of viability may be non-viable, and in which the flow, the function, the potentially to recover is unlikely. The viable myocardium may be stunning, may be hypernating, and may be chronic ischemia. In the stunning myocardium, the flow is preserved, but it is still viable, and it is likely to recover if ischemic injury does not persist or become repetitive, may benefit from revascularization. What about the hypernation? In hypernation, we have reduced flow also, preserved function, reduced function, likely to have part of full recovery if adequate reversal can be achieved. About the chronic ischemia, we have preserved at rest, impaired stress, the metabolism is normal at rest, increased at stress, the function is preserved, and also may benefit from revascularization. Here is also in 2018 the importance of revascularization and hypernating myocardium depending on the percentage of hypernation. So far, the increase in the hypernation area from A to D, A it is 5%, B 10%, C 15% hypernation, D 20% hypernation. So far the hypernation increased, so far the possibility to get benefit from early revascularization versus medical treatment. And again here we cannot pass without passing through these very important Canadian Cardiovascular Society guidelines about patients with heart failure and reduced left ventricular ejection fraction, which are more likely to experience significant improvement in left ventricular ejection fraction after successful coronary vascularization if they demonstrate. And let us notice here, reversible ischemia or large segment of viable myocardium more than 30% in nuclear stress testing, to this assessing the viability is important. Reversible ischemia or more than 70% hypernating myocardium on PET scanning. This is another modality. Reversible ischemia, more than 20% of the left ventricle shown as viable using dobutamine stress echo. And finally, less than 50% wall thickness scarring shown by late gadolinium enhancement on CMR imaging. So in the Canadian Cardiovascular Society guidelines, they are using all the modalities for assessing viabilities before taking the decision to proceed for revascularization or not. This is also one of the fantastic diagrams here, which I think most of us practically use it. It is also in the Journal of Thoracic and Cardiovascular Surgery by the Oxford group. Ischemia, cardiomyopathy, ejection fraction less than 35%, no angina. If yes, candidate for revascularization. If yes, we do coronary angiography. If disease suitable for revascularization, we have to do viability testing. If large burden of viable myocardium, heart team review for revascularization versus optimal medical therapy. Another important graph here, which is recently also published in the American Heart Association by Mario Garcia in Circulation. Suitable, if the patient is suitable for revascularization, if yes, we assess the evidence of ischemia. If there is an evidence of ischemia, we have to proceed to revascularization. If not, we have to assess the extent of scar by CMR. A very important percentage is here we have to know that below 25%, we have to proceed for revascularization, and if the scar extension is more than 50%, the patient should be kept on optimal medical therapy. But there is a gray zone here from 25 to 50%, and if we are falling in this gray zone by CMR, we have to do what's called the evidence of metabolic or contractile reserve to assess if it is present, bus to revascularization, if not, optimal medical therapy. We know from the STETCH that assessment of myocardial viability does not identify patients who will have the greatest survival benefits from adding CABG to aggressive, and this is also the result from Part 2 trial using the PET scan. But there is some limitation of this trial which is very important to mention. Patients were selected for viability testing individually at the physician discretion. Number two, patients represent a subpopulation of STETCH which are less than 50%. The number of patients without substantial viability was small, about 114, which limited statistical power. Use of two different imaging methods for assessing myocardial viability and their limitation of specificity and sensitivity. As I mentioned in my second slide, the limited specificity and sensitivity for SPECT and dobutamine stress echo. Analysis limited to SPECT and dobutamine echo without BIT and without cardiac MRI, I think this is a pitfall for this trial. Also in the guidelines, we have a debate. In the American guidelines, they are 2A to do viability. In the European guideline, it's 2B to do the guidelines. Actually, I have a bunch of cases to prove this evidence, and it is also recently published in 2020. This patient is 38-year male, familial hyperlipidemia, smoker, progressive heart failure over several months. Clinical examination revealed decompensated heart failure. ECG Q waves, ejection fraction 35, coronary angiography 75, stenosis in the proximal LED, CMR 25 to 50% scar area. So that's why the technetium is done for this patient with a small perfusion defect. That's why this patient is getting benefit from the viability combination between the CMR and PET scan for the decision making for doing the revascularization of this patient. The second case, 72-year-old woman, hypertension, diabetic, chronic kidney disease, dyspnea worsening over 24 hours. Her physical examination demonstrating S3 gallop and bilateral inspiratory rails. ECG T-wave inversion in all pericardial leads, elevated troponin, ejection fraction 40, and we can see and appreciate here in her coronary angiography, mid to distal LAD lesion. It's the technetium show moderate anteroapical perfusion defect at rest that decreased in size after 24 hours, so improving viability. This patient referred for CABG. Despite the complexity of increased her procedural complication, despite this and the presence of viability by technetium, this provides a justification against the risk of revascularization by using the viability. And here is the last case, 78-year-old woman with hypertension, acute decompensated heart failure, ECG, sinus tachycardia, left anterior hemifascicular block, Q waves, S-segment elevation, anterior pericardial leads. Cardiac enzymes are normal, but there is renal impairment, create 2.2. Coronary angiography showed several obstructive lesions in distal LET and diagonal branch, but here the technetium had the rule. Showed a large anteroapical perfusion defect at rest with minimal improvement after redistribution. The patient was recommended for optimal medical therapy. Why? Because here her history suggested that she experienced recent MI. Her angiogram demonstrated obstructive coronary disease in LAD territory corresponding to the transthoracic echo finding. Sorry, I need 30 seconds. 30 seconds. 30 seconds. Okay.
لو سمحت. 1 minute.
Okay. She had coronary anatomy consistent with her wall motion abnormality on transthoracic echo, but she was also high risk of procedural complication because of her complex coronary anatomy and kidney disease. That's why the decision here made upon the viability, the lack of viability on her technetium study indicating scar on LED does not provide a justification against the risk of revascularization. I'd like here to mention that those 3 cases are recently published 1 month ago in the American Heart Association journal, The Circulation, which helped us a lot for the for taking the decision. And finally, we have to wait for the REVIVE trial, which is using the CMR as a tool of viability for the decision making. And thank you for your attention.